And so at ESMO this year, we had an update of ARASENS, and then data for the very first time from ARANOTE and PEACE 3. And so if we can start by just refreshing everyone on the ARASENS study and what was new in the poster that was there at ESMO.
Yeah, I think we talked about ARASENS already with the doublet versus triplet, and now we're using the triplet in some select cases. So ARANOTE was a trial that was a non-US trial where patients with newly diagnosed metastatic hormone-sensitive prostate cancer were randomized in a 2-to-1 fashion to darolutamide plus ADT versus ADT alone. And there was a median follow-up about 2 years at this point. The results were just presented at ESMO with the primary endpoint being radiographic progression-free survival. And so the ARANOTE investigators, they met the primary endpoint of radiographic progression-free survival with about a 46% reduction in the risk of progression in the ADT plus darolutamide arm versus ADT alone. And the median PFS was not reached in ADT plus darolutamide arm versus about 24, 25 months in the ADT alone arm. There is a trend toward overall survival, but it's too early at this point the interim analysis is showing a trend toward overall survival, but we need more data to see that. And the trial also met its secondary endpoints, not OS yet, but time to castrate resistance, time to next treatment, PSA progression. So all the secondary endpoints, there was a significant benefit in the ADT plus darolutamide arm. And I think really notably was that the side effect profile was very good in the ADT plus darolutamide arm with very limited side effects that darolutamide seemed to be adding to the ADT. I think fatigue was 6% with ADT plus darolutamide versus like 8 or 9% with ADT alone, so it was larger in the ADT alone group, and otherwise it didn't seem like darolutamide was adding much in terms of side effects. So I think this is a really nice trial because we finally have our data that ADT plus darolutamide backbone has a PFS benefit. And hopefully we can add this to our armamentarium of ABI and Enza and apalutamide for our patients. And maybe get insurance to cover this ADT plus ARSI backbone without always having to use the docetaxel, because I know we've kind of run into some issues, and maybe we can talk a little bit about that more, whether you guys are using ADT plus darolutamide alone without the docetaxel in practice. But yeah, I think it kind of opens up options for patients, and I'm eager to look at the OS data and see what the FDA does in terms of approval of this.
Yeah, I definitely think this was a needed trial. I do have some patients that I pursued darolutamide without the docetaxel for triplet therapy. I had one patient who has very severe heart failure, and with his cardiac medications, well, for those reasons, I didn't want to put him on abiraterone prednisone, and enzalutamide and apalutamide actually interacted more severely with his cardiac medications than darolutamide, for example. And I think, collectively, we all probably already believe that darolutamide is certainly, probably no worse than enzalutamide and apalutamide, and might have some benefits in terms of toxicity profile and in my case, drug interactions. So I think it's something that we probably already wanted for our patients to have as an option for ADT plus ARSI. But obviously, if it can get FDA approved, that'd be a huge benefit. I was a little bit surprised that they were able to have the ADT alone arm in their trial, since we already know that ADT plus ARSI is better than ADT alone. But again, if it helps get the drug approved, then I'm all for it.
And I believe that trial was maybe 70% high volume too?
Yeah, the benefit was in high volume and low volume, and patients had visceral mets. And again, yeah, I think that this did come up, but it was like a non-US trial.
Non-US trial,
so
right.
The justification is that perhaps in some of these
those
places
wouldn't have had access to ARSI.
Would have just gotten ADT alone and didn't
Yeah.
even have the opportunity to get an ARSI.
And it was a 2-to-1 randomization, I think.
That's 2-to-1, yeah.
And I think it was all done before abiraterone went off patent, so at least in the US, so there wasn't really an option that didn't cost $10,000 a month, and I assume median income in these areas was sort of at that level maybe. So I think it fit into its time frame. I do wonder, because there were a lot of high volume people and there was no docetaxel, what the practices were like. Were those doctors, did they have docetaxel available? And just like we all thought, probably more than half of our high volume patients, we don't give docetaxel even when we have it. That were those the patients that were enrolled in the study, and did those doctors also have patients that they thought would tolerate docetaxel they didn't enroll? Or was it some scenario where they enrolled patients who might have, was it an access issue to docetaxel, or for some other reason that those patients weren't offered docetaxel? It doesn't really change in how we interpret the results. It just, I'd be interested to know.
Yeah, in community, as we tend to see a little more older patients, and they have diabetes, they have heart failure. I think there is definitely a drug interaction, prednisone-related hyperglycemia, which usually needed in arbitron. So we certainly think that we always struggle to make decisions whenever I go through the pharmacy check, and some of the AR agonists, as we talked about, enzalutamide, apalutamide, where we have to change some of the medicines or dosage. One thing I have seen, that not having skin rash issue with darolutamide is great, because I think these are all patients are male, and they tend to not as good patients in my experience to deal with the rash management. And all my, when they have a rash, they have a very low threshold to stop, and their rash tends to be worse, much worse than I think, in my opinion. So I have been shifting more towards darolutamide-based treatment. At least we all think they are all similar. Their data point outcome is very similar, but I think tolerability has improved and compliance have improved when we have less side effects with these medications, because we are expecting these patients to stay on this medicine, especially on hormone sensitive case, up to 2, 3, 4 years median time. So I think compliance is a big challenge.
Yeah, fall risk, seizure risk, brain fog, and similarly, I, like Risa, have had issues with getting darolutamide approved without docetaxel, which has been a challenge when you know that the side effect profile is better, fewer interactions. So I think this is great that we have this.
Would anyone need to see an overall survival benefit, assuming it gets approval in this space? Would anyone need to see an overall survival benefit to feel comfortable prescribing it?
My answer is
yeah.
no.
I think we're probably all, are we all doing this already?
I think we're all
like
doing
we're all.
Yeah, I think
it will be helpful and just solidify what we think, but I think we all know from the other studies they are similar, and there is already a trend, so I think it's already practice changing, and hopefully payers also agrees. I agree, as Dr. Wong said, that I had challenges with payers to get the darolutamide, and they'll say, oh, patient is not getting chemotherapy, we're not going to get approved. And so now we have a data to support that it does help, and ADT plus darolutamide is a very valid therapy for even in a low to high volume disease. And one thing I would say that it at least helps us also when patients are not a chemo candidate to go to the high volume patient just using ADT plus darolutamide.
So I think we can talk about the next study, which was, I have to admit, I was pretty shocked by the result, and it was so exciting to see that this was a oral presentation at the presidential session of ESMO. I really wish I was there to see Dr. Gillison present her data. This was an investigator-initiated study run by the EURTC for patients, and enrollment began in 2015, and it was for patients with castration refractory metastatic prostate cancer. It was really just right before the combination of an ARSI plus a GnRH analog became the standard of care in hormone-sensitive disease. So all but 11 of the 440 patients on the study had ADT alone without abiraterone as an accompanying agent. And so the design, they enrolled 446 patients, a 1-to-1 randomization of enzalutamide versus enzalutamide plus 6 doses of radium-223. And the eligibility, as you might expect, patients had to have predominantly bone metastasis. They were allowed to have received docetaxel in the hormone-sensitive setting as per charted STAMPEDE, and 30% of the patients had, in fact, received docetaxel in the hormone-sensitive setting. The primary endpoint was radiographic progression-free survival, again using our old friends, the bone scan and CT. And the top-line result, the study met its primary endpoint with a hazard ratio of 0.69 in favor of the combination of enzalutamide plus radium-223 versus enzalutamide alone. The median progression-free survival was 19.4 months versus 16.4 months. The 24-month radiographic-free survival at sort of the landmark analysis at 2 years was 45% versus 36%. And strikingly, the overall survival results had the exact same hazard ratio, 0.69, overall survival advantage in favor of radium plus enzalutamide versus enzalutamide. And to be honest, having seen the results of the abiraterone plus radium ERA 223 study, I would have said that would be almost impossible to imagine. But the data, those are the data. The median overall survival was 42 versus 35 months. And so those are really the top line data. What I thought was interesting is we know from the original SLEMTA study that radium in a somewhat more advanced setting and patients who had to be symptomatic, this study was for minimally symptomatic patients. But for symptomatic patients, there was an improvement in terms of symptomatic skeletal events. In this study, in PEACE 3, there was no benefit in terms of the rate of symptomatic skeletal-related events, nor in the time to pain progression, which I think is really interesting. I don't know if anybody has a hypothesis why that might be the case in the face of the rPFS and OS data.
I think an important just comment to add to great overview of the trial is that the trial was amended partway through after I think 119 patients had been enrolled to mandate the use of a bone strengthening agent, so denosumab, because of the results of the ARA 223 study of abiraterone plus radium versus radium or abi alone, where they saw a large number of patients have skeletal related events, and the trial didn't meet its endpoints. So I think that was very smart of the EORTC investigators to go back, mandate the use of a bone strengthening agent, and then I think it allowed them to meet the primary endpoint of rPFS, and there was a OS benefit as well. It's still interim analysis, but there's also an OS benefit. So.
Yeah, that's a great point about the bone strengthening agent. I think it tells us we have a lot to learn about what's happening in bone with radium and the effect on the osteoclasts and osteoblasts and versus the cancer cells. Just there's a lot we have to understand about the biology. It's interesting that radium has not really been used that much in its current approval. I think a lot of people have had the experience it doesn't affect the PSA. It used in the setting where it's approved. I don't think I've seen a lot of obvious responses in terms of radiographic, again, bone scans are really difficult to interpret, I think is part of the issue. So I think these are really striking data in that setting. And I think the big question is, how are we, if we assume this leads to approval in the setting they conducted the trial, castration refractory prostate cancer, how are we going to apply it now in the era where most patients are getting enhanced ADT in the hormone sensitive setting?
And that's a question I always, I tend to, right now, mainly I've been using radium-223 is patients who have isolated bony mets, who have a slow PSA rising on a novel AR agonist, who are, where I see the PSA going from 2 to 4 or 5. We do the bone scans, there's no visceral mat on a CT scan. And I tend to, you know, discuss with my nuclear mat colleagues and decide, you know, is this the time to use radium-223 and kind of bank the Pluvicto-based treatment for future. But certainly there's some risk of bone marrow suppression and so forth. But I've been curious how you have been using, especially with this data, and if it starts getting approval in that right setting.
Another question I'd really love to know the answer to is there some special synergy between enzalutamide and radium-223 that led to these results? And you would wonder, this might be a potential trial design, patients who are on, let's say, abiraterone plus GnRH analog in the hormone sensitive setting, and now they become castration refractory. Then let's say enzalutamide plus radium versus maybe docetaxel as the next, as a randomized trial. Is there something really special about that combination? Or I think you have a great point that radium may work better the earlier you use it. And I remember especially when we were waiting for radium to get its FDA approval and become available, in that year, I forget what year it was, but we didn't have a lot of other options, and patients were really pretty sick. They already had low counts. They were very symptomatic, huge burden of disease, and the radium didn't really help those people. A lot of them got really, as you said, cytopenias. So I think that's maybe really not the setting to use it. Like you said, probably earlier it works a lot better. But I really wonder, is there something kind of magical about the enzalutamide combo, and how do we test for that?
And we know from so many trials that there's like a synergy between radiation and hormonal therapy, radiation to ADT, radiation plus ADT plus ARSI from CMP, like in you know, very high risk patients. So I feel like this is again another form of, there might be some sort of radium-inducing double-stranded DNA breaks in prostate cancer cells, and then coming in with the hormonal therapy and exploiting this synergy between these two therapeutic approaches that we've seen so many times in prostate cancer.
I believe there's some data for continuing or having enzalutamide on board with Pluvicto as well, right?
Retrialing,
that
absolutely.
That was an ASCO of this year.
Yeah, and we're doing that.
Yeah.
So, yeah.
I think some of that is hypothesized to be due to upregulation of PSMA expression, which you wouldn't think would apply to radium, but I think there's just a lot of work that needs to be done. And just now that we see this activity, it just hopefully will generate some trials with clinical endpoints and some translational studies.
I think the other point too is, are you seeing these patients who were the patient population really in your clinic in the trial? Folks who are just on ADT monotherapy, which comprised the majority of folks on this trial, really they're seeing, you know, there was only a small percentage of folks who had seen abiraterone previously and a small percentage of folks who had seen docetaxel. So really you're seeing the person who comes in for ADT alone, and if so, is that really the person who you're thinking about starting enzalutamide and radium on? Or were there decisions that went into just, let's give you a hair of ADT and see how you do? So I think that, in addition to all the other things that we have in our armamentarium for castration-resistant prostate cancer, Pluvicto we've alluded to, you know, making sure they don't have BRCA mutations, these homologous recombination repair deficiency, and then obviously we never want to miss an MSI high. So we do have other things in different trials, and so I think it's a loaded question, but very exciting data.
Great point. And I'd love to ask the investigators, did they collect samples for translational studies to just exactly what you mentioned? Can you predict who's going to respond to radium based on mutational analysis or gene expression analysis?
Yeah, I agree with Dr. Kelly that this is a vanishing kind of population, that everyone's getting treated up front with 82 plus ARSI, hopefully in the hormone sensitive, metastatic hormone sensitive setting. And so who's really presenting that hasn't gotten Enza or Abby or now Daro maybe in the metastatic hormone sensitive. But again, it's great to have options for our patients, right? It's great to be able to say, based on the person in front of us and your comorbidities and the biology of your disease, these are the things we can do. Of course, if they have a visceral crisis, they have Mets in their liver, they have a ton of pain, like docetaxel will probably be the way to go, but great to have options.